All right, greetings, mavens of anatomy and physiology. Here we are in the kidney still. So I left off with this slide, the last slideshow. This is glomerular filtration rate, GFR. You're going to want to remember that acronym, GFR. That is how much glomerular filtrate are you making at any given time. And most of this, as you saw, most of the small molecules, small ions, end up in the glomerular filtrate. Red blood cells, large proteins, they do not make it into glomerular filtrate. They are still in the efferent arteriole. Now here's the factoid that I'm most interested in. I think I mentioned this last time. 60 times a day you are filtering all of the fluid of your blood. That's pretty amazing, and then only a small percentage makes it into the urine. 1 to 2 liters is typical. Right now, we got to talk about the specific parts of the nephron and what they do. So, you have to get this concept, this idea down here. You're going to run into terms. So, glomerular filtrate. Glomerular filtration is whatever gets out of the glomerulus into this part, into the proximal convoluted tubule. That is called glomerular filtrate. Do not confuse this with urine. It is not urine, not yet. Urine, we can call it urine over here at the collecting tubule, but it is not urine until it gets there. Okay, so 2 other terms that you need to understand quite well. As I mentioned before, this whole thing about tubular reabsorption and tubular secretion. What I would tell you to do is don't focus on the word tubular so much. Yes, it has to do with the tubular system of the kidney. Yes, of the nephron. It does. However, focus on this word, reabsorption. Reabsorption simply means whatever is inside this tubular system, you're going to bring it back. So this purple arrow, that represents reabsorption of something, whatever is coming, was in the glomerular filtrate. You want it back. If you want it back, you reabsorb it. There's lots of stuff like that. On the other hand, there are some things that not enough of it ends up in the tubular secretion, and the tubules, this tubule system, all this tubule system following that nephron loop, the distal convoluted tubule, into the collecting tubule, the collecting duct. There are some things that did not get in there or are not in high enough quantities. You want to get rid of it. If you want to get rid of it, you want to secrete it. So, any process whereby you're bringing something out of the tubule back to the blood vessels, that's called reabsorption. If you want to take it out of the blood vessels, the capillaries, into the tubule system, you are secreting it. Doesn't matter what it is. So you're going to see these terms a lot in the next few slides. All right, so let's follow along. Okay, so here's your slideshow again. Same kind of thing, same process. Reabsorption is bringing stuff from the tubules back to your blood vessels. And remember, the blood vessels are going to eventually leave the kidney. They're going to go on to the rest of the body. If you don't want it in capillary systems, in the blood vasculature, you want to get rid of it. That means you want to secrete it. So tubular secretion, movement of wastes from the capillaries into the renal tubules out of the body. Tubular reabsorption, movement of substances from renal tubules in the interstitial fluid, and then they diffuse into the peritubular capillaries. Or sometimes they're actively pulled into. Maybe you're going to see some things where you want to bring them back against the concentration gradient. All right. So let's get into tubular reabsorption. Remember, reabsorption. It's in the peritubular capillaries, or it's in the peritubular system. You want to bring it back out. Okay, so you can bring it. How can you bring it How can you bring it out of the tubule system back into the capillary system? You can actively transport it. That takes energy. If you want it bad enough, you're willing to pay the energy that's necessary. You're moving things against the concentration gradient. Limited transport capacity due to the number of carrier proteins, right? You only have so many proteins that can do this kind of thing. And they have to be pretty specific, so you have to know what you want. Now, you may have the renal plasma. That means the amount of fluid in the blood is reached when they transported a substance in the plasma, then the active transport mechanism can handle. Now, if you have too much stuff in the tubule system that's going to be excreted and you want some of that back, you can only take as much of it back as you can handle. If there's more in there than you can handle, well, the rest of it's going to go out in your urine. There's just no other choice. So, an example, glucose. You want to keep as much glucose as possible. You want to hang on to those amino acids. They are in the glomerular filtrate. All these small things, creatine, lactate, citric acid, uric acid, ascorbic acid, ions, all these things are in the glomerular filtrate. You want as many of those things back as you possibly can get. There are transport systems that are specific for them. Osmosis, that just means water. Remember, water, the movement of water is osmosis by definition. Well, a lot of water ends up in the glomerular filtrate. You want it back. You don't want to give up that water. So, it has to osmose, or by the process of osmosis, it has to be brought back into the capillaries. And then endocytosis, so there are small proteins that end up in the glomerular filtrate as well. They made it through the podocytes, and you want them back. You know, you don't want a lot of these small proteins. You spent some time breaking them down or building them up, or somehow you wanted those things. Well, now they're going to go out your kidneys unless you bring them back. So that whole process is reabsorption. All right, most of the reabsorption of most of these things occurs in the proximal convoluted tubule, PCT. All right, so afferent arteriole, glomerulus. Now you have the glomerular filtrate is here. Here it is. It's in the proximal convoluted. Proximal means it's just close to the glomerulus. And it's convoluted because it's twisty-turny. Round and round and round she goes. So look what comes back. Sodium ions. Yes, you want them. Bicarbonate ions. You betcha. You want them. Right? Water. You want it. Absolutely. Chloride, where sodium goes, chloride will follow. Where sodium goes, water will follow. So all of these things. So this is all called reabsorption. All of these things are reabsorbed. There's a statistic. It's not on this slide, but you get about 60 to 70% of the sodium that is in the glomerular filtrate. 60 to 70% ends up back in the blood. 60 to 70% of the water ends up back in the blood. Most of these things end up back in the blood right here. Okay, the opposite issue is secretion. There are things that you want to get rid of, right? So these are substances that move from plasma in the capillaries that surround this tubular system. You want to get them into the renal tubules, into the collecting duct, and send them out in the urine. Typical thing is wastes, right? The waste products, you want to get rid of them as much as you can. There are some active transport mechanisms that help, but most of the time, things like drugs, ions that you'd like to get rid of. Potassium is one of those that ends up in higher quantities in urine than it is in the blood. And secretion of hydrogen ions is important in regulating the pH of body fluids. So if you're in metabolic acidosis, you would like to get rid of some of your hydrogen ions, which would help to balance out the pH of your bloodstream. Your kidney is well suited to do exactly that. So secretion, most of secretion happens from the distal convoluted tubule. So you can see here's the proximal convoluted tubule up there. Here is the nephron loop right there. This is this segment, this colored segment there. This is the segment that we're really looking at now, the distal convoluted tubule. That's where most of your tubular secretion occurs. Now, you see sodium come along, sodium comes along. You'd like to take back some of that sodium. Well, there's a pump. There's a sodium-potassium pump. Pulls sodium back up into the bloodstream. But it comes at some cost because you have to trade a sodium with a potassium. So you end up having more sodium in the bloodstream and more potassium in what is now becoming urine. This happens in the distal convoluted tubule. So this whole section here is the distal convoluted tubule. And then this part here is the collecting tubule or collecting duct. You have the same process going on. Sodium out, potassium in. Now here's the thing too. Whenever you see sodium move, you have to think water follows. Water follows sodium. But water does not follow potassium. I know they each have one positive charge, but they're different. They're treated differently by cell membranes. The net result is this. Wherever sodium goes, so this arrow, sodium is going out into the capillary system, that means water will also go. H2, oh gosh, I need to get like a pen or something. Ah, it's terrible. Anyway, that's H2O. H2O follows sodium. So wherever sodium goes, water goes too. That means you're concentrating the urine. Think about that. You want to save that water. You're bringing it back into your blood vasculature. That means there's less water in your urine. So you're concentrating the urine. So that's good. You want to hang on to as much water as possible. But this whole process is called secretion. Secretion means you're getting rid of potassium into urine. In this particular case, there are other things that are also secreted from the blood into what becomes urine. And it even tells you right here, if you forget this, you see right there, tubular reabsorption means is you're taking it from the tubes into the blood. Tubular secretion is you're taking potassium out of the blood and putting it into the what is becoming urine. So here's the concentrations of things that are in urine. All right, so notice the categories here. Plasma, right? There's your blood. Glomerular filtrate. All right, so that's what got through into the glomerulus into Bowman's capsule into the proximal convoluted tubule. What you're going to see is almost universally these are the same. So these small ions, small things, get through, they're about the same. So plasma and glomerular filtrate are about the same for these small ions over here. But now look what happens. What your body, so you have to think of the logic of the body. What does it want? Well, your body does get rid of some sodium. Okay, so some sodium goes away. However, in fact, you're actually taking some of the sodium from the glomerular filtrate and putting it back into the body, as you saw on the previous slides. But really the key thing here is you take this fairly small quantity of potassium and you increase its quantity quite a lot, or increase its concentration quite a lot in urine. So potassium is not quite a waste product, but your body is okay with getting rid of potassium. So see, it concentrates potassium in the urine. Calcium is about the same, so there's not a big change there. Magnesium, 5 times as much magnesium in urine as there is in plasma. Chloride, not a ton of difference, but there's some difference there. The biggies, look at the biggies down here. Sulfate. Sulfate is considered a waste product. You want to get rid of sulfate, very much concentrated in urine, not very concentrated in glomerular filtrate. Likewise, phosphate, very much concentrated in urine, not so much of it in blood plasma. So phosphate and sulfate are considered waste products. Your body wants to get rid of that stuff. Whoops. Likewise, glucose in plasma, 100. Glomerular filtrate, 100. It goes through the Bowman's capsule very easily. It's in glomerular filtrate. But look what your body does. You have no urine, or you have no glucose in urine. None. Zero. Zippo. If you have normal glucose concentrations in your blood, you will have no glucose in your urine. This is one of the ways that we diagnose diabetes. We start to see urine in, or we start to see glucose in urine. That is a red flag for sure. On the other hand, urea is a breakdown product of amino acids or proteins. Proteins that are broken down end up with urea. You see urea gets in from the plasma into the glomerular filtrate, no problem. But look what your body does. It concentrates urea in urine. Well, that's a big, huge waste product, and it is a big, huge component of urine, is urea. Uric acid is a breakdown product of DNA breakdown. You eat foods. The foods you eat a plant, you eat an animal, doesn't matter, I don't care what you eat. You're eating cells. Those cells have DNA in them. You're breaking down that DNA. Well, that's considered a waste product for the most part. Glomerular filtrate, there's that much. But look at this in the urine. It concentrates the amount of uric acid. So your body looks at this and says, I want to get rid of it. Creatinine, same thing. Creatinine, a fairly dilute quantity in glomerular filtrate, but your body considers it a waste product. It concentrates it. So these are big, big waste products. Urea, uric acid, creatinine. Your body wants to get rid of them. Your kidneys have a way to concentrate that. Okay, now, your kidneys must regulate the amount of blood coming through them. I mentioned previously that if you're lying down and your blood pressure is low and your heart rate is low, you don't have a lot of pressure going into your kidneys. Well, your kidneys need to be able to regulate the pressure that's inside them. What you're looking for is what you're trying to do is to maintain this quantity called glomerular filtration rate, GFR. You would like to maintain that in very tightly controlled range. And so it remains relatively constant because your kidney regulates that. Now, how it regulates it, it's called auto-regulation. That means it regulates itself. So there are certain things that your kidneys can do to regulate the amount of flow, blood flow, coming into the kidney. The kidney is also monitoring overall systemic blood pressure, and it can regulate that too. So we're going to look at how that happens. All right, so your kidneys want to keep glomerular filtration rate constant. Here are the mechanisms how they can do that. Autoregulation. We're going to look into how that happens. What does the kidney do to regulate itself? Sympathetic impulses keep GFR constant in changing blood pressure conditions. So that means if you get up and you start to go for a run, your blood pressure goes up, your heart rate goes up. That means you would pump more blood into your kidneys. Well, your kidneys don't want more blood because ultimately you would make more urine, and that would mean in 5 minutes into your run, you'd have to pee. And 5 minutes later, you'd have to pee again. And 5 minutes after that, you'd have to pee again. You want your kidneys to regulate this. So it will regulate pressure in the afferent and efferent arterioles because they're wrapped with smooth muscle. So if you get up and go for a run, sympathetic nervous system constricts arterioles. It constricts afferents and efferents simultaneously to limit the amount of blood that's coming into your kidney. And then for general or systemic blood pressure, your kidneys are involved in this process that are known as the renin-angiotensin system. And I would actually expand that to say they're called the renin-angiotensin aldosterone system. We're going to get to why that's a big deal. There are other hormones that also regulate the flow of blood, pressure, come out of these are ones that come out of your heart. The atria produce this thing called natriuretic peptide, and ventricles produce a similar kind of peptide hormone that also regulates blood pressure. Let's talk about these. Okay, the renin-angiotensin-aldosterone system. Usually we refer to this as it used to be called the RAS system, now we refer to it as the RAAS. Renin-angiotensin-aldosterone system. But what is all this stuff? Okay, so we got to start with the liver. The liver makes a protein. The protein is called angiotensinogen. If you recall, I hope you recall, when we talked about blood clotting, there were so many things that had this ending on them, ogen. Ogen means this is the precursor product. This is the inactive precursor product. The thing in front of it is the active component, right? So the angiotensin is the active component. Angiotensinogen is a precursor. It doesn't do anything. It's floating around your bloodstream. Your liver just kicks it out, and it's floating around. And it's not doing anything. But it's waiting. It's waiting and waiting and waiting. What is it waiting for? Your kidney senses a decrease in blood pressure. Right? So how does it do that? It has baroreceptors that are part of the juxtaglomerular complex. And so and that is right where the afferent and efferent arterioles enter and leave the glomerulus. So they're sensing pressure at that point. If they sense a decreased blood pressure, it doesn't matter the reason. If they sense a decrease in blood pressure, the cells in that complex are going to make this hormone. This hormone protein, it's a protein called renin. What is renin? Renin now enters the bloodstream, and it's an enzyme. Now I know it's not called reninase. Yeah, you might wish it were. But it's called renin. It's an enzyme. What it's going to do, it is going to cleave off a portion of angiotensinogen. It's going to make it active. The active form is called angiotensin, of course. But in this case, it only makes angiotensin 1. Angiotensin 1 is not very active. Doesn't really do much of anything. However, the next step, angiotensin is now in the blood. As it flows through the blood, it comes in contact with the inner surface, or the endothelium, of lung capillaries. So, those cells have, on their surface, they have this enzyme that is called angiotensin converting enzyme. ACE, for short, because that's too hard to say. So we call it ACE. What does that do? That converts. Of course, it converts angiotensin. Well, it converts angiotensin 1 into angiotensin 2. Ah, this is the one. This is the one we're really looking for. Angiotensin 2 has a number of activities that it stimulates or directly causes to happen. This is a really important one. So angiotensin 2 directly has an effect on the tone of blood vessels. It vasoconstricts arteries and arterioles. Okay, so it's going to constrict them. That's an increase in pressure immediately. It also stimulates the release of aldosterone, and it stimulates the release of ADH. Now, ADH is called antidiuretic hormone. We're going to get into its specificity in a moment. So this is the process. A quick summary. Liver makes angiotensinogen. It just floats around your blood, doesn't do a thing. The kidney senses a decrease in blood pressure. It kicks out renin. Renin goes into the bloodstream. Renin is an enzyme that converts angiotensinogen to angiotensin 1. Still in the bloodstream, angiotensin 1 goes into your lungs. The surface of the lungs have an enzyme called angiotensin converting enzyme. Converts angiotensin 1 to angiotensin 2. Angiotensin 2 is the active component here, and it does all of these things. Vasoconstriction, increased aldosterone, increased ADH secretion. It also increases your thirst. You got to go back to cardiac physiology. Remember, when you increase blood volume, you increase blood pressure. How do you increase blood volume? You need more fluid. If this stuff makes you thirsty and you go drink more water, your gastrointestinal system will suck up that water and put it into your bloodstream. Bingo, more volume. More volume, more pressure. All right, so we got to talk about these hormones. Aldosterone. We won't get into the cardiac natriuretic peptides. There's one from the atria and one from the ventricles, but they operate similarly to aldosterone. And I'm gonna show you pictures of exactly how they work and how they do their thing. The other one that you need to learn about is ADH, anti-diuretic hormone. If something is a diuretic, it means it makes you pee. It makes more urine. So caffeine, if you drink a beverage with caffeine in it, we consider that a diuretic. If you drink more of that, you need to pee more. So that's called a diuretic. If you don't want to pee more, if you want to conserve water, you need an anti-diuretic. Well, that's what ADH does. We're going to talk about these. So, here's our generalized nephron from the glomerulus, proximal tubule, nephron loop, distal tubule. All right, ADH, anti-diuretic hormone, has its primary effect, and it is released from the posterior pituitary. It's actually made in the hypothalamus, and then it is stored in the posterior pituitary, and then is released to the body. What it does is it comes into the collecting tubule, right? So here's the collecting tubule, and you see all these little arrows, H2O, H2O, H2O. How is all this H2O getting out? The H2O is, ADH has the effect all along the collecting tubules. It has the effect, I think it's in the next slide, let me show you. Yes, in the next slide. It has the effect. So what you're looking at here is you're looking at, this part. I'm going to blow that part up in the next slide. Now, and there you are again, right? So so here's the collecting tubule. You've gone through proximal convoluted nephron loop, distal convoluted tubule. Now you're into the collecting tubule or the collecting duct. Inside the cells that line the collecting duct are these proteins. These are called aquaporins. If you break that word down, aqua is water. Pore is pore. It's literally a water pore, a water hole. It's a protein that is specific to allow water to move through a membrane. So here is the tubular fluid, right? That's inside the collecting tubule. You want some of the water out of there. ADH comes along and allows the formation of more aquaporins. What does that do? That allows water to flow down its concentration gradient, just like this dotted arrow, right into where? What is this? Oh, look, red blood cells. Hey! So you are taking water directly from the collecting tubule into the capillaries that surround it. That's what ADH does. ADH allows more pores for water to leave the tubule and go back into the bloodstream. So that's what we're talking about here. This is the effect of ADH on urine volume. So it would decrease the amount of urine volume because it's pulling water out, and it would concentrate the urine, as it says here, concentrated urine. So that's ADH. Here's the role of ADH in regulating urine concentration and volume. Here you are. If body fluids are too concentrated, so you go through these processes. If the body fluids are too concentrated, that means the osmolarity of those fluids is rising. That means you don't have enough water. You have too many ions, too many other things that are creating an increased osmolarity in your blood. You need more water to dilute that. How do you do it? ADH. ADH is released by the posterior pituitary, And now you know where it goes. Reaches the kidneys, last part of the distal tubule, and mostly in the collecting tubule. Mostly the collecting tubule, but a little bit of the distal tubule. Causes water reabsorption by osmosis, but it does that because it creates more aquaporins. And water flows through those. And urine becomes concentrated, and urine volume decreases, but you save some water. Now the opposite is true if body fluids are too dilute. What does that mean? You've got too much water in there. The osmolarity of your blood drops. Right? Concentration of water in the blood increases. That means a decrease in osmotic pressure. You can't have that. That's not the way you want the osmotic pressure to be. 300 milliosmoles most of the time, everywhere in your body. That is a stimulus to reduce ADH release in the posterior pituitary, so it stops releasing ADH. Less ADH reaches the kidneys. Aquaporins are not produced. They are not put into the cell membrane. Water stays inside the collecting tubule and goes out of the body, just like here. So that would be this situation. Less ADH, water stays inside the collecting tubule, out it goes, and you have a more dilute urine. That's how ADH works. Now, I also want to tell you about the hormone aldosterone. Okay, aldosterone, we've already talked about it. Aldosterone comes from the cortex of your adrenal gland. Aldosterone has its effect on the distal tubule. Now what it does is it specifically pulls sodium out of the distal tubule. So, what does that mean? It reabsorbs sodium. It causes sodium reabsorption. So I'll try to draw an Na. And you know how badly I draw with this little thing. Na, sodium. I told you before, where sodium goes, water goes. So sodium leaves the distal tubule. That means water leaves the distal tubule. Okay, so you're going to have a more concentrated urine. That is where aldosterone has its effect, on the distal tubule. There's aldosterone. Aldosterone takes sodium out of the distal tubule. Water follows. So that also has the effect of sparing water, of concentrating urine, of keeping more water in your body. It would also have the effect of increasing your blood pressure. All right. Now you have this thing called a countercurrent multiplier. Yeah, this is just a big fancy term for a special way that the nephron loop, or the loop of Henle, helps to concentrate urine. The whole mechanism, the whole thing is referred to as a countercurrent multiplier. Now, I have to tell you to make sure to watch. There is a video, a great video, in the YouTube channel that I've set up through Baker. There's a really great, it's just a black and white video of this woman who describes how the countercurrent multiplier works. It's an excellent video. It really, it's a very short video, and it helps to explain what I'm going to talk about here, because it's a confusing concept. But there's two things you have to know. Two very, very important details here. The descending, let's start with this, the descending limb of the nephron loop. So you got and I'll show you a picture in the next slide, but I'm just going to draw a quickie here. Right, here's the proximal convoluted tubule. You know that there's glomerular filtrate in there. And then it goes down into what's called the descending limb of the nephron loop. This descending limb is permeable to water. Water can leave if it wants to, but solutes, especially sodium, chloride, potassium, they cannot get out. So here, water can leave, water out. And drawing, oh, that's terrible. So water can leave, but everything else must stay. that means as it goes down, 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 whatever is in there, the glomerular filtrate gets more and more and more salty. And then it makes the turn, the big turn. It loops. Now it comes back up. Now this part is called the ascending limb. The ascending limb over here is the opposite. It is impermeable to water. Water cannot get out. Can't go in, can't get out. But it is permeable to sodium and chloride ions. That actually actively reabsorbs it. It pulls them in. Okay, so what does that all mean? What that does is, let's go to this picture. What it does is, and here's the picture, right? Water out, water out, water out in the descending limb. Then you make the turn. So what does that mean? This is called a hypertonic fluid. Hypertonic, why is that? You've taken water out. It's just like if you took water on your stovetop and put a bunch of salt in it and stirred it around, and so it's dissolved. And then if you boil a bunch of water away, if you boil the water away, the salt gets more and more and more concentrated. You've done the same thing here. You've created a hypertonic fluid, salty, super salty, down here. And then you turn the corner. When you come up here, now it's super salty. Now you let the salt leave. Sodium chloride come out, sodium chloride come out, sodium chloride come out, sodium chloride come out. Right, so this is it again. If you start off with a normal solution, you take water out of it, you get a salty solution. Right, if you keep doing that, you get, as time goes on, you get more salty, and as time goes on, you get even more salty, because you let water come out here, but you don't let any of the ions come out. Then you turn the corner, and now you pull the ions out, and that makes it super salty at the bottom. At the loop, it's very salty, but at either end, it's isotonic at that end of the loop, and it ends up being hypotonic by the time you've gone into the proximal convoluted tubule. That's why that video that I put on there, it really explains this quite well, and it shows you how you develop this salty solution, this hypertonic solution down here. That's important for water reclamation in the collecting tubule, because this goes on into of course the distal convoluted tubule, and it does some other stuff, but eventually this whole thing drops down there. And this one drops down there. And now you have this super salty hypertonic fluid that this tube is flowing past, and you can decide, do I want to let the water come out, or do I want to hang on to the water inside the urine? You get to make choices and decisions, and then, ADH can have its effect at this part of the collecting duct. That whole process is called the countercurrent multiplier. All right, so here it is again. Now, here we don't have any blood vessels. We're not showing you what's happening to the blood vessels. We're just showing you what's happening in the tube. You make this super salty solution at the bottom of the tube, of the loop of Henle, and then you make it less salty by the time you get back out of that. All right, so what? Now, if you put blood vessels in there, remember, water is coming out on this side, on the descending limb, water comes out. What you end up getting is this sort of highly concentrated sodium chloride on one side and less concentrated on the other side, and that sort of makes this back and forth roundabout pathway that allows you to adjust the concentration of water. I know we're looking at salts here, but wherever salts go, you have to think water is also following the salts. If it can follow the salts, it will follow the salts. This allows you to adjust water concentration in the body. All right, so this is a table, the overall summary of all the bits and pieces of a nephron. How does a nephron work? Remember, you got two big parts to it. You have the renal corpuscle, and the parts of that are the glomerulus and the glomerular capsule, or Bowman's capsule. And then you have the renal tubules, And there are 3 parts to the renal tubules. Right, there's a proximal tubule, there's the nephron loop. That's part of the nephron loop. That's part of the nephron loop. So proximal tubule, nephron loop, and distal tubule. Now we break the nephron loop into 2 pieces. Right, you have the descending part of the nephron loop and the ascending part. And then these are the descriptions of what those things do. Once you're out of the tubule system, you're into the collecting duct. So you need to understand these are the anatomical features on the left side. So that's anatomy. This is physiology. So make sure you run through all those steps to understand the anatomy and the physiology of each section. So these are considered waste products, urea and uric acid. Right? So here's where they come from. Amino acid catabolism, the breakdown of amino acids. Breakdown product is urea. Breakdown product of nucleic acid metabolism is uric acid. These are both acids. You want to get rid of them. But the thing you have to remember too about the kidney is that it does not eliminate these things completely. What it does is it reduces the concentration of these things down to a level where your body can tolerate it. That's the important thing about a kidney. Now we can also use these components, if we measure these components in your blood, we can measure urea, we can measure uric acid, and we can get a pretty good idea of how efficiently your kidneys are operating. And if these are building up, these products are building up in your blood, that tells us your kidneys are not working well. And we can monitor that. There are other things too that we can monitor in your blood that tell us kidney function. Now, they also vary by other reasons. Urea, because it's a breakdown of amino acid catabolism, if you eat a lot of amino acids, that means if you eat a lot of protein, you're going to tend to have more urea in your blood. 80% is reabsorbed. That means, isn't that crazy? It's a waste product, yes, and your body would like to get rid of it, but your body can handle 80% of its normal concentration in your bloodstream, and your body is just fine with that. 20% is excreted into the urine. That's all that's necessary to maintain normal homeostasis. Get rid of 20% of the urea, your body's fine. Down here, of uric acid, 10% of the uric acid enters the urine through tubular secretion and is excreted. So you get rid of 20% of urea, you get rid of 10% of uric acid, your body's fine with that. That's normal. That's homeostatically normal. Now, urine composition. As you suspect, 95% of urine is water. You got metabolic waste products. We just talked about a couple of them. Urea, uric acid, creatinine. Those are 3 big waste products that leave your body in urine. Of course, you're going to have ions, a lot of potassium. You're going to have sulfate ions, phosphate ions are pretty common. Trace amounts of amino acids are common. As it says here, varying amounts of electrolytes. But you should not have any glucose in urine. So, 600 milliliters to 2.5 liters is considered normal urine volume. 50 to 60 mils of urine per hour. So that's 1 mil per minute, right? 60 mils per hour, 60 minutes, 1 mil per minute. You're making about a milliliter of urine every minute. And of course it varies with fluid intake, environmental factors, etc. Now you gotta store it, right? So you make the urine in the kidneys, it's transported through the ureters. Each kidney has a ureter, transports it down to the urinary bladder. In the urinary bladder, that is your storage vesicle. Right, so here's the path. Nephrons, collecting ducts, then openings in the renal papillae into minor calyces, major calyces. Renal pelvis, you're still in the kidney at that point. Now you're out of the kidney here, ureters, you're out of the kidney. Urinary bladder, stored in the urinary bladder, and then exits the body through the urethra. Oops. Now, how do you know when you have to pee? Well, I mean, you know when you have to pee, right? So the urinary bladder is distended. It's a muscle. It's a smooth muscle. The urinary bladder is a smooth muscle. It gets filled up, starts to fill up. Stretch receptors in there. Tell your brain. They signal the micturation center. So micturation is is peeing, urinary output, or urine output is considered micturation. You have a micturation center in the sacral part of the spinal cord. It's making decisions. It's feeling the amount of stretch in those receptors. How many signals per second are those stretch receptors sending back? Parasympathetic nerve impulses travel to the detrusor muscle, which is the muscle of the urinary bladder. Now, the urinary bladder will contract rhythmically. As it starts to contract, that's when you're going to get the sense that I have to urinate. Oops, I need to urinate. Now, you don't urinate at that point, or hopefully you don't, because you have this thing called the external urethral sphincter. Yes, that means you have an internal urethral sphincter too. The internal urethral sphincter is not under your control, but the external one is under your control. It is skeletal muscle. The internal sphincter is smooth muscle. You inhibit the micturation reflex by impulses from the brainstem and the cerebral cortex to prevent urination. That means you are voluntarily saying, oh yeah, I gotta pee, but I'm not going to. Then, at some point, you decide to urinate. You say, okay, I'm at a toilet now. Now I'm going to release the external urethral sphincter, and the pons and the hypothalamus are going to facilitate a micturation reflex. They're going to cause the urinary bladder to squeeze the detrusor muscle to push the urine out through the urethra. Detrusor muscle contracts, right? Internal urethral sphincter relaxes, and urine is expelled through the urethra. Micturation reflex subsides, detrusor muscle relaxes, internal urethral sphincter contracts, and the bladder begins to fill with urine again, because your kidneys didn't stop creating urine during this time. You just got rid of whatever was there. This is amazing to me. Urinary bladder holds 600 milliliters. That is more than 2 cups of urine. That's a lot of urine. But the urge to urinate begins at about 150 mils, 150 milliliter. But 600 milliliters, that's a fantastic amount of urine. Please don't try to make your bladder hold that much. That's a lot of fluid. All right, so I believe that's it for the urinary system. Up to the bladder and the urethra. And now, the bladder and the urethra, you're going to see this now in the reproductive system. When we start talking about male and female reproductive system, we're going to get more in the urinary bladder and the urethra and other anatomical details and the physiology of those systems. So stay tuned for those. That's coming up very soon.